If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today, we're going to cover what to do when we encounter thrombocytosis on a full blood count, always focusing on what is relevant in primary care only. I have based this episode on Haematological guidance by Camden CCG, Manchester Foundation Trust, and King's Health Partners. The links to them are in the episode description. Right, let's jump into it. Thrombocytosis is when the number of platelets is high, which is usually defined as a platelet count above 450. But before moving on, let's clarify the terminology. Should we call it thrombocytosis or thrombocythemia? There is an important difference. Thrombocytosis is much more common and arises as a secondary response to another condition, which is why it is also known as reactive thrombocytosis. On the other hand, thrombocythemia, also called primary or essential thrombocythemia, is far less common and represents a myeloproliferative disorder in which the bone marrow produces platelets in an uncontrolled abnormal way. Another important distinction is that patients with reactive thrombocytosis have normal platelets, so the risk of thrombosis and bleeding is relatively low. On the other hand, patients with thrombocythemia have abnormal platelets, which increases the risk of both blood clots and bleeding complications. From a clinical perspective, thrombocythemia often presents with splenomegaly and a platelet count greater than 1,000. So let's have a look at the possible causes. Causes of thrombocytosis include iron deficiency anemia, which is one of the most common causes of reactive thrombocytosis. When iron levels are low, the bone marrow increases its overall activity in an attempt to compensate for the anemia. Although iron deficiency limits the production of red blood cells, platelet production is not restricted in the same way. As a result, the bone marrow produces more platelets. In addition, inflammatory signals associated with chronic iron deficiency can further stimulate thrombopoietin pathways, increasing platelet numbers even more. This is why thrombocytosis often resolves once the iron deficiency is corrected. Another cause is malignancy, because some tumors release inflammatory cytokines that eventually increase platelet formation. This reactive response is common in several solid cancers, particularly the LEGO cancers, that is, lung, endometrium, gastric, and esophageal cancer. Another cause is general inflammation, where cytokines stimulate excessive platelet production. Also infection, which can cause transient reactive thrombocytosis. Postsplenectomy and hyposplenism, such as in celiac disease, since the spleen normally helps remove circulating platelets. Postoperative states, where inflammation and stress responses increase platelet counts. And finally, a primary myeloproliferative disorder such as essential thrombocythemia. How should we respond to thrombocytosis? The criteria for urgent hematological referral are a platelet count exceeding 1,000, which raises concern for a myeloproliferative disorder and a significant risk of thrombosis. Splenomegaly, which may indicate a primary hematological process such as essential thrombocythemia or myelofibrosis. A recent history of thromboembolism, given that thrombocytosis can contribute to recurrent clotting events. A platelet count above 600 in a patient at high risk of thromboembolism or cardiovascular disease, since the combination significantly increases clinical risk. Neurological symptoms, which may reflect microvascular complications associated with very high platelet counts. Any signs of malignancy, given that multiple cancers can cause reactive thrombocytosis. Any significant abnormal full blood count indices, which may suggest a bone marrow disorder rather than a reactive process. And finally, if there is abnormal bleeding. And let's stop here for a moment and discuss how it is possible that thrombocytosis can be associated to a high risk of both thrombosis and bleeding. On one hand, thrombosis risk in thrombocytosis is due to the high number of circulating platelets, which makes clots more likely. In addition, inflammation causing reactive thrombocytosis can also create a prothrombotic environment. Together, these factors increase the thrombosis risk. On the other hand, bleeding risk in thrombocytosis can occur for two main reasons. First, in primary or essential thrombocythemia, the platelets produced by the bone marrow are structurally and functionally abnormal, and these abnormal platelets do not work effectively, so clot formation is impaired. Secondly, thrombocytosis may affect the von Willebrand factor. Von Willebrand factor is a protein that helps platelets stick to damaged blood vessels and to each other, making it essential for the first steps of clot formation. However, when platelet counts become very high, the excess platelets bind and remove the most active forms of von Willebrand factor from the circulation. This leads to a functional depletion known as acquired von Willebrand syndrome. It explains the paradoxical situation in which a patient can have thrombocytosis and yet be at increased risk of bleeding. Going back to the management, if none of the urgent referral criteria are present, we will investigate for underlying causes by arranging the following initial tests. A repeat full blood count to confirm that the thrombocytosis is persistent, a blood film, which may reveal abnormal platelet morphology or other features suggestive of a myeloproliferative process, inflammatory markers such as ESR and CRP, since inflammation is a common cause of reactive thrombocytosis, ferritin and iron studies, as iron deficiency frequently elevates platelet counts, and we will consider a celiac screen because celiac disease can lead to hyposplenism or iron deficiency, both of which are associated with thrombocytosis. If the patient is asymptomatic and no obvious cause is identified, we will repeat the full blood count 4 to 6 weeks later. If the thrombocytosis persists above 450, we will refer to hematology routinely for further assessment. So that is it, a review of the assessment and management of thrombocytosis. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.